Sir, you are always, I think you are my mentor itself. So, good morning, chairpersons and dear friends. This topic, I never spoke at anywhere, which Dr. Bansi has given to me. Why it is not coming? Yeah, my slides, hello. So Fibroscan, I think when he gave this topic to me, rather I was I can say I was not doing anything what to do in this talk, because I myself, when I was giving sometimes we are giving a report of the Fibroscan and seeing the interpretation from the lab, and that appeared that there is sufficient for me. But Dr. Bansi also told that when you give a talk, I just keep 2 slides for the history of diabetes. I thought maybe some speakers might have shown many things, but I think this Elliot Joslin, this statement that the diabetic who knows the most lives the longest, I think nothing better statement is in the field of diabetology. I think other things are also here, you can see that, so I think I've just kept this. All the statements by this Joslin, which told as a father of diabetology, I think I have not time to tell you, but you can take a pic of this. And you just see here, a well-trained nurse is of more value than the patient doctors. So important, the man who gives up active outdoor life and is promoted to an office chair by this change becomes a promising candidate for diabetes. I think everything he captured. And learn as if you have to learn forever, live as if you die tomorrow. So I think this is very, very important. Now also the history of this Fibroscan. Starting early concept in 1990s, then from 90 to 2000 there was a developmental phase, and the first commercial launch was formed by the France, that is the EcoSense, that known as the Fibroscan. And thus becomes the first commercial transient elastography device. Initially they validated it only in chronic hepatitis C, showing high accuracy in detecting the advanced fibrosis and cirrhosis, and now you are well aware that now it has become so important in our day-to-day practice. Sometimes I wonder, every day whenever I do my echo in my clinic, and whenever I put a probe on the liver as a routine in all my cases, even a patient coming at the age of 20, 25, 30, everyone is showing fatty liver. What is happening, I don't know. So here comes the concept of Dr. Bansi, which this symposium is going on. So I think the first principle is that comes the fatty liver grade 1, grade 2 in your ultrasonogram, and that basically we know by CAP, I will tell you detail. But steatosis is nothing as a fat in liver, and what is fibrosis? That is the scarring of liver. So 2 things are very important. If there is a fat in liver you are getting on ultrasonogram and you are ignoring it, don't ignore it. जैसे किसी ने बोला कि किरोसिन तेल जो है फैला हुआ है देश में, एनी टाइम तीली लगा के हटा सकते हो, वैसे ही फैट इज लाइक दैट किरोसिन तेल. एंड आई थिंक लेटर ऑन, if there is fibrosis, that becomes something like कि जो लीवर में आग लगी थी वो जल गया पूरा. So what is this fat inside liver? So 2 things are very, very important in Fibroscan. One is the cap and second is the stiffness. That is known as cap, which you know here. So this is very important, that's we are going to. So there is a technique which is a vibration pulse and ultrasound waves to measure liver stiffness. This is a technique, and one part of technology is that we are doing it with the Fibroscan because this is a brand name by EcoSense. I am not going in detail for that, but you can see here that we have 2 things in the transient elastography. One is the Fibroscan, which is a very fast screening tool, but it is a blind technique and limited in ascites and obesity and many other conditions. And the shear wave elastography is a ultrasono guided detailed elastogram. Even you can take a focal, the focal area you can scan in this Fibroscan, but in a special cases you can go for this SWE, but today we are going for discuss this transient elastography. So you can see lots of accuracy, but I am not in detail. But I told you that we are going to take care of the three things in the MFLD. One is the stereosis. We have an ultrasonogram, grade 1 to 3. Then we are doing a CAP by Fibroscan. And proton-derived fat fraction, MR technique, again it is not for day-to-day practice. Then you are doing inflammation in the liver that you can do by the liver enzymes and markers. And last part is when you are going to tell that you have got a fibrosis, that also gives you idea from this Fibroscan. So two things we are getting from this Fibroscan. One is the steatosis and second is the your fibrosis. So this is, and then today also very important development has occurred. You are aware that ELF has come. Just a single blood test can tell you whether patient is suffering from fibrosis or not. So lot of things are happening. So this is what the Fibroscan is here. But I will again tell you that don't go for a straightforward to prescribing or advising for Fibroscan. Do a FIB-4 score. I will say you in the next few examples. So if it is more than 1.3 or FIB-4 score, which is very simple to do in your clinic, then after that you decide whether you have to say the patients to spend around 3,000 or 4,000 or 2,500 for this Fibroscan, because this can exclude the presence of advanced fibrosis after, so you take the first care with the FIB-4. So just remember that this is a second line test, and if you do, if the FIB-4 is more than 1.3 and in elderly after 65 years of age, if it is more than 2, and then you go for the Fibroscan. That is, we have got two techniques I told you. One is the enhanced liver fibrosis test and then LSM. So let us see what is that. So now till now I told you that we are going to now, suppose the FIB-4 score is 1.9. So now I think that, oh well, I have to go for the Fibroscan, and I am going to see what is happening with the LSM, that is a liver stiffness measurement, which will tell me about the non-invasive quantifications of liver fibrosis, and that will also give us one report about the CAP, that is the control attenuation parameters. तो दो चीजें भी रट लीजिए और दो चीज को बार बार समझ लीजिए कि LSM and CAP. This is very important in the Fibroscan, and machine you are seeing here. And then we have lots of this. You can see the how this we are going to grade the F0, 1, 2, 3, 4 for the LSM, that is the for fibrosis according to the values, and then we understanding the CAP scores again less than 180, 285 or what that is. Then we do S0, S1, S2, 3. So this is very simple, not very complicated. So this is what the Fibroscan is here, that we are giving a shear wave. Shear wave is speed, and we are calculating the stiffness. You can see. So low speed, the low stiffness. High speed is high stiffness. You can see here. Pulse echo is generated, and this is how to going. And this is how we are getting the propagation map. The liver tissue we are going, and we are time we are seeing with the liver tissue. I am not going for details for that. Let us come straight forward. What is this ultrasound attenuation rate? Unit is decibel per meter, and then we are seeing the shear wave coming like this, and that's below skin. So what is attenuation rate? Because the moment you are giving a shear signal intensity, that is attenuating, you can see then accordingly you are seeing the rate example. So this is how the liver tissue, or if there is low attenuation rate, this shows like this. And you can see if there is giving you high attenuation rate, it is like this. So now it becomes clear, and accordingly you can see, this is the data you can see. Now let us see, I will just take 4 or 5 minutes more. This report we are getting. Now you have seen many things in this report. One is the CAP is 232, E is here 6.1, median is showing 1.42, here saying the IQ are 0.3, and then this is one thing is 5%. So what is the meaning of all that? That is the important thing to understand. Let us see. So this is showing E is 6.1 kilopascal. So QR is 0.3. So if it is 5%, it is only saying you that it is very reliable scan. So you also must take it. So if it is less than 30%, you can see here, then it is saying you that it is a reliable scan. If it is not meeting this criteria, it is not reliable at all. And measurement is here showing 11, suppose. and meets again the quality criteria, at least more than 10 is required. And shear wave speed is showing 1.42, and then the cap is coming 232 decibel per meter, that is measuring your the liver fat. So we are not only going to see only this part. The only way I am only saying 232 for the cap and 6.1 for that Pascal. Because everything is important here, whether it is reliable or not, the measurements have been taken well or not. This is very important. So this is how this result telling us that 6.1 kilopascal is slightly above normal, but below the threshold for significant fibrosis. So consistent with F0 to F1, no mild fibrosis. And what is this cap telling you? Here, this result is 232 decibel per meter. It is just below cutoff, you can see. Cap is, if this S0 you need it at less than 238, then there are S1, S2, S3 severe. So just below the cutoff steatosis, indicating you that there is normal liver fat, S0, or very minimal fat. So again, the reliability is more than 10 valid readings. QR median is less than 30%. Here it was 5%, so this scan is very reliable. So this is the how you are going to tell your patient ki final impression, giving that Fibroscan shows normal liver fat because its cap is 232 and no significant fibrosis because it is F0 to F1, and this is a near normal result. So then you are saying, oh, continue the healthy lifestyle. If you have risk factor, keep monitoring early, and if there is no risk factors, this scan is reassuring you that there is no immediate concern. So this is how important a test is. Now see this case, 45 years old male, obesity, risk factors for MSLD there, and then this your median liver stiffness is coming 3.2 kilopascal. So you can see the normal range is 2.5 to 5.5. So this is normal here. IQR is 13%, that is again reliable because it is less than 30%. Measurement is valid because it is 11 by 11, and cap is showing 250. So definitely this case is normal because in this case when they did the Fibroscan letter, suppose they have did it earlier and it was showing you less than 1.3, that's excluding you the advanced fibrosis. So there was no need of doing that in this case. But in this case, if the Fibroscan cap is showing 270, Fibroscan was 13 point K, and here the Fibroscan was done, that was 3. So it was above the cutoff. So in this case, you are again saying, you are telling you that this is highly suggestive of advanced fibrosis or even cirrhosis, F3 to F4, and in such cases, it is possible that you should refer to case to hepatology. So this is how important test is there. I will have only 2 minutes, so I will not show all these things, but only thing you to know that in chronic hepatitis, in hepatitis B, or in some other conditions, in portal hypertension, when there is congestion, there is some different cutoff that is important to show you, and there are some confounders also, like know the ALT, and congestion, alcohol, obesity, cholestasis, non-fasting, inflammation, inexperience. So these are some of the co-founders of this Fibroscan which should be taken care of. And again, depends also on the many phenotypes. In obesity and CKD differs. In even heart failure, pregnancy, the levels, the cutoff could be different. Even the lean type 2, there is discordance, so many other things are there. Even in post-dengue, if you are doing that, there could be different things, so these things must be remembered. And India specific pathway should be taken care of. So my last slide is here. Inflammation, that concluding point, that is a very important technique which you can, is reproducible quantification of liver stiffness. This correlates well with the histological fibrosis, staging in MSLD, viral hepatitis and other CLDs. And this control attenuation parameters, which is known as CAP, allows this simultaneous grading of hepatic steatosis, that is fact, that is S1 to S3, adding value which is beyond the fibrosis assessment. So this also thresholds vary with the etiology. I told you, if their case is viral hepatitis or cholestatic disease or BMI and ALT level, so that should be integrated with clinical and biochemical context, and this is a most useful to rule out the advanced fibrosis. stratify long-term prognosis, guide surveillance. So I think again I will tell you that this is a very, very important test, and Dr. Bansi has made me more wiser by giving this topic, because I had known zero before that, and Dr. Akash also helped. Thank you very much. So the Fibroscan has turned the liver from